Welcome everyone to another VITA Academy webinar. Today we have Mr. Mark Wagenseil. Hi Mark, how are you doing?
Hello, super duper, how are you?
Excellent. I hope all the everyone that's joined us is doing well as well. Today we've got kind of a unique webinar going on. Mark gets tons of questions, and here at VITA we get tons of questions on how to utilize the teeth or how to do a certain process or workflow or talk about different classifications of setup, and you know the questions go on and on and on and on. So today what we're going to do is more of take those questions that you've always asked Mark about or here at VITA, and we'll have Mark kind of go over methodically over those questions and illustrate you know, whether hands-on under the camera or through a PowerPoint, either way, to help you understand some of the concepts that he's been doing over the last few years. Mark, I think Mark kind of came up with this topic concept, which is very good because we, like I said, we get so many questions that it's hard to keep up, in fact. Mark is a VITA certified global trainer for VITA management consultant. He's a licensed denturist and dental technician with over 30 years of experience. As the owner of Heritage Denture Center and Heritage Dental Lab in Edmonton, Alberta, Canada, he has spent his career focusing on how dentures integrate into the mouth and body. He inspires a unique awareness of occlusion and professional growth. So Mark is a denturist, so he comes from a little bit different of an angle because he actually sees the patient. So some of the concepts that he'll go over is from that perspective as well. So Mark, thank you again today for helping us out doing this webinar. And I am going to go ahead and turn this over to you.
Okay, good morning, everybody. Hello, welcome. Woohoo! We do not slap teeth together. Welcome to this session. This is an interactive session. It's different. So instead of me putting on PowerPoints and pictures and everything, we're going to do more interactive. So this is an opportunity for us to share as a community. So first off, thanks to Jim McGuire and his team and VITA North America for their kind support of our professions and the support of us trying to take care of our patients. We're all trying to be superheroes, and we're trying to be a superhero for the end user, which is our patient. And what we do is extremely difficult. We do not slap teeth together, and we have a difficult job because we're trying to build dentures that fit on soft tissue, and they usually are going into a senior citizen. And as we get older, we have health concerns and our body ages, and it's very difficult. I am 53 years old. Started when I was 17. It's been 37, 36 years of my life now building dentures. I love what I do. It's the right path for me, and I very much am so grateful for the opportunity to share my experiences with you. As we share as a community of professionals, we learn and we grow, and we're just trying to, again, take care of that patient and to be a superhero for them, whether we do that directly for them or whether we do that via a doctor or a dentist. We're still here for a patient. So as Jim said, this is an interactive. This was a concept that we just thought that we can open it up, and whether it's a case or you have questions, type them into the chat box. Jim interrupts me or jumps in, and we answer that question. So this is your opportunity to pick my brain, but also to share as a community and share your experiences, because that's what helps us learn and grow as we move forward. The example that I want to use is I've had several patients, gosh darn, like dozens of patients in the last, say, while that have had knee replacements. And before, you'd go to the hospital and you'd be in the hospital for a week, and then physio and in a physio-based hospital. And now they're doing knee surgeries, day surgery. So it's a day surgery. So they go in, get the knee, and they're out at the end of the day, and they're doing exercises the very next day. Different. And that's because we're pushing it. And that's our goal, and why I want to give back to professions I love, because we have to share, we have to push and move forward. And that's what makes us better. in regards to new technology being integrated, or even just sharing and pushing. We're trying to do that for our end user and our patients. It was interesting that you can go for knee surgery now and have it done in a day, and it stays surgery. It's just a different concept. So that's kind of what spawned, again, this interactive option here for us. So I want to share with you a lot of patient experiences to also funnel through some of the questions, because again, a lot of what we do and how we adapt and conduct ourselves is based on the patient. So we have codes of conduct and standards of practice that we follow in regards to how we're taught, and conduct and standards of practice of how we deal with a patient. The funny thing is and I'll say this directly, is I've still never met a textbook patient, even though we study from a textbook. Still haven't met a textbook patient. So the funny tongue-in-cheek on that is, of course, everyone's a little bit different, and where we learn is how to massage things and walk into that gray area. And that's when you really learn your craft. It's one thing to learn it from a textbook perspective, but the next is to integrate it and take your years of experience to combine that together, and then move forward and grow, and then re-educate yourself as you go through your career to stay current and fresh. So thanks for joining me. Thanks for taking time out of your busy days to sit down and join us, for Jim and I, and to share. And we appreciate you being brave to type in the questions, and I mean that sincerely, to put yourself out there, and we share as a community. You're not obliged to provide your name, but you can start typing in your questions or cases that you have. And my goal is to try and talk you through and help as we try to be that superhero. So again, thanks for joining, and I'm very blessed and fortunate to be able to have this experience with you. A few things that we wanted to do to get started was some of the questions that we use and have is, Mark, what have you seen the change when you changed your philosophy from say 20-degree teeth to a mortar and pestle tooth like VITA? Have you really seen the difference? And what spawned my change of occlusion was, I used to build dentures using 20-degree teeth. This was our standard that I grew up with and was taught in school, and we built a 20-degree denture. And this is, again, our gold standard of what we do. And we would have working and balancing occlusion, and working and balancing occlusion was spawned from when we built dentures. We saw that they would shift in the mouth because they sat on soft tissue. So we thought if we balanced the cusps, that would provide stability for a patient. And so the issue lies, though, is that the usual masticatory system doesn't work on working and balancing. We work on a teardrop chew cycle, and we mince our food. So from a natural occlusion perspective, our natural teeth are designed like a mortar and pestle, where you have a cusp sits into the fossa and it minces and hammers the food. And while it does that, your tongue is mixing it with saliva, and then it rolls the food into a ball called a bolus, which you swallow. So this is kind of like it's like a masher. It's there to mince food, pulverize it so that it can be fine enough when mixed with saliva to stick together. That way it doesn't break apart in your throat when you swallow it, and then when it hits your stomach is always moving, and it can break apart that ball. But the food is fine enough now that the enzymes and acids in your stomach can dissolve the particles. Then that slurry goes into your intestines that absorb the nutrients from it, and then the rest is collected by the colon and expelled from your body. And what's interesting is when you look at the chewing cycle, and what a denture is there to do is to take the place of teeth when the patient had natural teeth. But what doesn't change is the chew cycle and some of the fundamentals of your tongue rolling. You have to touch your teeth together to swallow, and then you swallow the bolus down. I started asking my patients about their bowels and whether or not they're on a laxative. You'd be surprised how many patients are on laxatives. And when you can rehabilitate someone and effectively improve their chew cycle, they can get off that laxative. And that's been very poignant for me clinically here to see that. But what I did was I took them out of a 20-degree teeth and put them into a mortar and pestle tooth. So what 20-degree teeth are is they're designed, it's again 20 degrees, it's a flatter concept, and they're designed to work and balance together, and it's more of a milling action. So it's like a mill, like when you mill flour, and it's there to mill. But to do that, you have to touch together and make it work, and that's where the denture rocks. So circling back to my earlier comment, what spawned my introduction and look to something different was I would build a denture, I would take impressions, final impressions, registration, open the vertical as required, set things up, working and balancing occlusion, put the dentures in, have the patient come back, and the patient would say, geez, Mark, the new teeth are looser than the old one, or geez, Mark, things are loose and the bottom still lifts. And you'd go, well, it's a bottom and it sits on less gum and you don't have any gum, and we use soft liners and this and this. And I got really good at explaining and trying to, again, pacify the patient. I would take the denture, I would take a check bite, I would remount it, and the patient would still come back and complain. And that's where we get cynical by saying, oh, it's just the patient's expectations and it's not realistic, it's just an artificial appliance. It should be seamless and integrate. So I wear glasses, it's an artificial appliance. When they fit well and function well, I shouldn't know I wear glasses. It should be seamless. And that's the idea behind this. Was when I started to realize 20-degree teeth, you don't chew with working and balancing occlusion. So what I did was I went to a mortar and pestle where we have the cusps and the fossa and mincing. And then the idea behind it is as it goes through, I just don't want the cusp touching the guiding planes to hit and slide into position. Whereas this concept, it's designed to hit and slide into position. That would rock the denture. So with mortar and pestle or lingualized occlusion per se, or lingo form from VITA, it's designed that the cusp comes in, doesn't touch the lower sides of the lower teeth, or the bowl as I call it, and it can go into position. And it's a more of a mincing action that has really cut down on my adjustment rate. So to answer the first question that came up that I put to the top of the list was, what has been most impactful in my career has been to understand and use my base knowledge of 10, 20, 30, 33-degree teeth, and then understand and step beyond to say, wait a minute, why was I experiencing these problems? So that the lower was loose, food was still getting under it, the denture didn't need to be relined, or gosh, I relined it 5 times already, it still isn't working. These things then came back to is that we're asking someone to use teeth that we specifically designed to have contact and work and balance. But I don't chew with work and balance. I chew in a teardrop where my cycle isn't designed to have the teeth touch and slide into position. And when I changed and rethought the concept and started to use a lingualized purpose-built tooth that has the main mortar and pestle, and the cusp comes in and touches, keep clear of the sides so that it can operate freely. I have patients now off of laxatives, and it's really significantly cut down on my adjustment rate. So that's the long-winded story to answer question number 1, that this has worked well for me and has reduced my stress and my angst and made me happier in my professional career because I have more stability and control. So whether you deal with the patient directly or indirectly through the dentist, this is a concept that you can set up. It sets up like 20-degree or 30-degree or 33 or 10-degree teeth. You can set them on a flat plane. You can set the upper first or the lower first. It doesn't matter. At the end of the day, what's different about this setup, although it appears somewhat similar to a 20-degree tooth, it does have a little bit more spacing and gapping in it. But it's the design of it is that the upper cusps can come into the lower fossas without impairment, without hitting the side walls or the guiding planes, and that rocks the denture less. I essentially, I don't use soft liners in my office anymore. I don't buy the product. If I need it, I have to outsource it, because I used to use a lot of soft liners, especially on flat ridges. I left school with the mindset of flat ridge, flat teeth, monosoft liner, to drop a brand name, but that was it. Flat teeth, flat ridge, soft liner. And I realized that that's not the case. You don't need it as what you thought you needed it, because you can control the hydraulics of the denture pushing when you switch to this mortar and pestle. Okay, Jim, any questions come in, or I'll go to my next one?
All right. I have a couple questions here that, how do I, any ideas on how to change my dentist to a more modern tooth design?
Yes.
So it's more on the practicality.
Yeah. I'm gonna speak candidly. I apologize. I'm gonna speak candidly. Okay. This is about money. So you're gonna hit them where they understand, and that's chair time and chair costs. So I'm glad you brought that up, my dear colleague, because this is what I had to experience and go through. So most denturists don't have a lot of practice management training. That wasn't a focus, especially when I went through school. But dentistry has a lot of practice management and a lot of practice management courses. So when you ask a dentist what are their operating costs, they should be able to tell you, and most likely can tell you to the dollar, of what it costs them to run their business. So what you're trying to do is you're trying to save an adjustment, because adjustments are expensive. When you use 20 degree, or excuse me, 10, when you use milling teeth, which are 0, 10, 20, 30, 33 degree style teeth that work in balance, your average adjustment rate on an upper and lower complete denture or a full is 2 to 5 times. So that patient is expected back 2 to 5 times. We accept that in the world of dentures. When you can identify it and ask the doctor, how many adjustments do you do? So out of the denture cases you do, how many adjustments do you do? So you're going to have to ask the office manager or the secretary to pull those numbers out of their denture patients, and you can tally up how many adjustments are typically done in a month, for example. And then you can, for example, switch and have the dentist switch teeth, and you'll see that adjustment rate drop and you have their attention. So we're going to go after the money aspect, because that's also what got my attention. So I went back and I counted up how many adjustments I would do in a week and in a month. So on average, you can expect a denturist to do 2 to 5 adjustments a day. That would be standard on a fairly busy practice. So you have to say, even if you pick 2 adjustments a day on a 5-day work week, that's 10 adjustments. 4 weeks, that's 5, 10, 15, 20 adjustments a month. You go, it's 20. Okay, on average, an adjustment is 20 to 30 minutes. So now all of a sudden, 20 adjustments at 30 minutes. Now all of a sudden, you are doing 2-3 days of nothing but free work out of your work cycle. If you look at your operating costs, so on average, these will fluctuate, of course, from city to city, state to state, province to province. A dentist's operating cost is usually about $800 to about $2,000 to $3,000 per hour, depending on how big their office is and how many staff. But you have to consider that the dentist, there's one dentist and he has or she has, say, 5 people working for them. That is roughly operating costs of, depending on rent and stuff, about, let's say, $1,000 to $1,500 an hour for them to operate, because they have to feed 5 people plus themselves, plus pay rent, and on and on. And that's one dentist with maybe 2 chairs for them and, say, 2 hygiene chairs. So you've got a 4-chair office, plus reception, sterilization staff, 1 or 2 assistants, and two hygienists. So their operating costs are roughly, say we'll just go $1,000 mark. And that patient comes in for one adjustment, and that's 30 minutes. You have to appreciate the dentist isn't making any money. So that one dentist is there to generate income per hour to make money to offset the operating costs. So you come in for one free adjustment per day. That's 30 minutes that the dentist is idle and not making money. The chair sits. It costs money because they're not generating revenue, and then you have to clean the instruments, clean the chair, clean everything, chart. That drains. So how you present this to the dentist is to say, look, I've done some homework. I want to suggest this to you. On average, the denture cases that you've been doing for us, you're generating about 2 adjustments per patient. That's about an hour of time per patient after insert. Your operating costs, gosh, sir or ma'am, must be $1,000 or whatever dollars an hour. So I want to suggest something that we can try and cut that adjustment rate down by half. So in this case, cut it from 2 to 1 or from 5 to 2 or 1 consistently. And I want to do that by changing the type of teeth we use. And our goal here is to build a product that fits better into the patient, because that's our end goal, but also save you stress and time and now money. So that has their attention because they understand that. I have seen that in action. I have lectured to that, and especially when you're in a room with doctors and you start asking them what their operating costs are and the hands are going up, they know what it costs. And when they can see that we can reduce the adjustment rate, reduce and address that operating cost issue, you have their attention, because really, what do they have to change? Well, teeth, and that's the lab's responsibility. All you have to do, doctor, is just give me the shade, but I'm not going to be using our old style anymore. We're going to say use VITA, and it's just, it presents like what you're used to, but it's now just a main lingual cusp that's going to be chewing the food versus milling, which is flatter this way. We're going to go to more of an open concept. Short of that, there's really not a lot of change for you other than never just grind the big cusp. You always want to touch into the bowl and watch the guiding planes. That's really the only change on the adjustments. So to help market that, that's how you would do it. You want to just go right to the dollars and cents, address the adjustment rate, and then offer a solution. The solution is to drop the adjustment rate so that everyone's more efficient. It cuts down on adjustments and saves time and money. So I hope that answers your question. That was a big one for me. We accepted, and I accepted adjustments as they were, because that was just part of the game with dentures. And actually, no, you can get a hold of that. And that was my professional growth and journey. And now I have a better control over that, and I'm much less stressed. And I can still operate a business, but I don't have to work as hard. And the old expression, you work smarter. So if you have any further questions, type it in, please. But that's how you can talk to the doctor directly about that. We just go right to the money. And again, I've done that in lectures in front of dentists, and boy, do you have their attention in a hurry, because they understand that. They understand the stress of dealing with patients. They understand the stress of that treatment room, and they understand that the receptionist's job is to keep that dentist in that treatment room generating money. That's how that works. The practice management and the dollar value is important to dentistry. And if you can offer a solution to help their efficiency and help that, boy, do you have their attention. And we're here to support you. So Jim's going to give you my contact information privately. So you can contact me privately, pardon me, and I can help you through that, but address it that way. Jim?
Yeah, so you keep mentioning mortar and pestle design.
Yes.
How does that relate to a dental term? They have not heard it in regards to dental. So if you can correlate that to the dental side, that'd be great.
Okay, hang on a second. This is a mortar and pestle design. So let me just grab a piece of paper and I'm gonna so everyone knows what a mortar and pestle is, right? You have a bowl and then you have your masher, which is that big mallet, and you put your seeds and herbs and things, and you sit there and you pulverize it using this hammer approach into this bowl, and you pulverize things in here. So it's a food terminology of a mortar and pestle, but our teeth are designed like this. So from a teeth concept, you have the bowl, which is the lower, which holds the food. Here is the big hammer. It's the lingual cusp of the upper posterior teeth. There's the buccal cusp, and this sits in here. So it's a larger cusp design compared to a milling tooth, pardon me, which is the 0, 10, 20, 30, such. And this is what pulverizes the food. So the lower brings the food here. It brings the food to get crushed by the upper lingual cusp. And the other secondary cusps, so the buccal lingual cusps, are there to help hold the food here to get mashed by this. So to now explain it from a dental perspective, it's taking from the food perspective to the teeth perspective, okay? Now, you gotta bear with me here 1 second, because I've gotta flip out and then I gotta find the right. Jim, can you see my PowerPoint?
I can.
Nice.
The superheroes.
Yeah. Okay. So that's a mortar and pestle. So the top picture is what that is from a food perspective. And now I showed you what it is on the bottom here from the natural perspective of teeth. This is a milling tooth. So milling is the top picture is like a mill. That's what we mill flour and grains with. You have to have two flatter surfaces with grooves cut into them, and then they grind against each other. So the bottom picture is our standard 20 degree tooth, and if you see, like, everything touches. And yes, we have some grooves cut into the teeth just like a mill. So when I looked at the teeth, I'm like, well, geez, it's a lot like a mill perspective, like flour. The cusps are flatter, and look at how everything contacts. And the teeth have to come together, and then they have to grind against each other to be able to mince the food apart. And that was the biggest change when you jump philosophies to the mortar and pestle, and again, the cusp sits in the bowl. It's the same thing here. There's the cusp, it sits in the bowl, and the bowl brings the food up and it gets crushed by the tooth. But you see there's more gapping here. So you don't have to mill it, it gets minced. It's far more effective. You need less chews to do the job. And when you do less chews, you're putting less hydraulic pressure down onto the ridges, and you don't need the soft liner. And that's why I've really reduced the soft liner usage to basically 0, because we're not overloading the gums as much, because a milling method, it takes longer, you need more chews. We want less chews, okay? So it's a different type of philosophy. Wait, I gotta get rid of my pen. Okay, Jim, next question.
Go ahead and if you have anything else, go ahead and and present it. And then anyone that does have additional questions, please send them through, and we'll fill it in as Mark goes through.
Nice. There we go. I had to get to the right screen. Okie dokie. There you go. Awesome. Now we got to flip it. Nice. Okay, so no, what am I doing? Let's go that way. Okay, so this way. Awesome. All right. Next question. This is an interesting one. This was sent by a denturist, and he said, Mark, I have a lot of times on dentures, I have patients saying that they can feel a space lingually when they run their tongue along the border of the denture. They feel a gap here about the molar area, and they put their tongue down there and they say there's a space, and I check it with pressure indication paste, and I reline it and I use direct reline material, and the patient still swears that the denture has a gap, and there's a gap between the denture base and the tissue. What's going on? And so I'm gonna shed some light on this. So to the denturists and the dental technicians, when you finish a denture, typically we would finish the denture, and you can see this, the flange is thick. So we would finish this denture and usually say it's 2 to 3 millimeters. And yes, we have a rounded edge on it, but this is the prime example of what you see. And so what happens is the patient's bending their tongue down, and they feel this here, and they can't feel it touch the tissue. So their tongue interprets, due to the thickness, that there's a gap here, and there in fact is not. The reason being is because, remember, on linguals, or excuse me, on the lingual we have an S curve. So we usually see a nice S curve, but when we finish a denture, rarely are we trying to address that S curve into the finishing. So what you want to do is you want to take this flange and you want to scoop it out in here. So right in this area here, you'll trim it out, you'll feather it in, and that problem goes away. So again, typically what we see is this here is it's just inadvertently too thick, and we didn't carve that S curve into the lingual of the denture. Like typically the S curve is here. Pardon me, one moment. Water break for Mark. So that S curve lies right there. So the S would present itself right here, and this mark here is typically where the molar is, and that's where the patient would feel that gap. That drove me ballistically nuts for about the first 5 to 10 years of my career, when patients would say there's a gap there, and I'd reline it and I'd repair it and I'd check it, and I'm like, look, there's no gap. Yes, there is. Yes, there is. And then my aha moment was I wasn't trimming the denture like an S. So you have to trim the denture like an S, okay, and incorporate that. So you can actually see it on the wax here. There's that S curve. You can see that S curve. So I trim out in here and turn that thing into an S, and the problem goes away. And I do not have that problem anymore. So a little bit of experience and bashing my head on the wall that I share with you now about, please, especially the dental technicians listening, carve in that S curve, please, and that problem goes away. And if you ever have the chance to talk to doctors and ask them if they've ever had patients experience that, it is quite common. And it's frustrating because we think it fits, but just that's what's causing it, is that lack of an S curve in the denture. Okay, so I hope that answers that question that was put forth. That's just an experience one there. Okay. All right. Allow me a minute to transition. Okay, So the next question was an explanation of, when I talk a little bit about the mortar and pestle and how it worked and why. So again, these are VITA lingualized, so it's VITA lingual form. Let me grab a template, sorry. So again, the way they set up very similar to what you're used to with 20-degree teeth in terms of the placement. Just what you notice on the tooth is that it has that larger lingual cusp. So that's from that mortar and pestle approach. So those are the cusps that are going to mince and break down the food. And that is held by the lower. So the lower is shaped more like a bowl, again, like the mortar and pestle. And then inside, so from the cusp tip perspective, the lingual cusp rests in these bowls, okay, that I've just marked in black. So that's these red ones coincide with the black. And that's kind of the main concept. And then what we want to watch for is when the patient chews, and the calibration of this is you just don't want the denture teeth to hit on these guiding planes and slide in. So everyone has a chew cycle. So everyone has an ability and how they chew their food. It's a unique cycle. We walk in a unique pattern. We talk in a unique pattern. We have a fingerprint. We have a retinal scan. These are unique to us. And I'm just now had a flashback of my mom saying, Mark, you're slouching. Pull your shoulders back. Mark, you're slouching. But we all have our postures and things that are unique to our body. And this is where we want to watch these uniquenesses, is where they can touch on the guiding planes. And so if I make any corrections to someone's occlusion, it's typically me adjusting in these areas that I'm marking in green to just allow for those red cusps to come in more unencumbered and land on that black dot, okay? The other big thing that I'll bring up now that you've heard me, and for those of you that know me, preach is we also have the freedom and center concept. And essentially the freedom and center concept is unique to only a few teeth on the market. The teeth actually have the ability in centric to slide left and right within centric. Okay, let me flip that this way. That's how it should be. To within centric, it can slide about a millimeter and a half. That's freedom and centric. All 0, 10, 20, 30, 33 degree teeth from any manufacturer does not incorporate that. When they build them, it's tight. There's no play in centric. So now you're asking a patient who cannot feel their denture teeth to accurately land centric without hitting and sliding into position. That can't happen. And then because the teeth themselves are so tightly knitted together that I showed you in that PowerPoint picture, it has to touch and slide into position, and that's what rocks the plate and breaks things. And that's where we run into the problems. And when we have that freedom and that little bit of play in it, then you don't have to bullseye land every time. This is still effective. This still minces the food, but we're just eliminating that hit and slide into position. That was, again, my huge aha moment. Okay. Jim, supplemental question, or I'll go to my next one.
All right, so what we've got is when you are setting lower molars, do buccal and lingual cusps be on the same plane, or should be some inclination? So I think it's kind of like a Curve-Wilson type question.
Yeah. So
posterior.
Okay. Yeah. Now I'm gonna say that you're talking specifically to lingual form teeth then. So I'm gonna answer that question specifically to VITA lingual form. So you're going to set these teeth like you would a milling tooth, like the 10, 20, 30 degree teeth. So the buccal and lingual cusps touch the plane. Okay, so you're leveraging the bowl, and that tooth sits typically flat. Okay. The hesitation you hear in my voice is sometimes I've had to angulate it, but that was because I saw it in the patient, and I knew there was like a tongue issue or just something told me that I needed to put the buccal up a little bit and tip that lingual down, just because of the way their tongue was moving. So there are some exceptions to the rule, because again, I've never met a textbook patient. So remember, some of us like ketchup on our scrambled eggs. What? And some of us don't like ketchup on our scrambled eggs, but that just makes us unique. So that's what this is. So typically, to answer your question, my dear colleague, yes, on the molars, flat. So you should have all the cusps touch flat, so that lower sits flat, from that curve of Wilson perspective, okay? Anything else is designed internally in the tooth, but the cusps would touch, okay? I hope that answers your question. If it doesn't, type it back to Jim for any clarification. Awesome. So the next question that I have is from a doctor, and they said that they have a patient with a complete upper denture, but to lower natural dentition. So we'll just say, for example, there's some lower natural anterior teeth, and this case has broken out the patient's upper left lateral repeatedly. I think it's now broken out 3 times or 4 times, and they keep repairing it, and it keeps breaking out. And their question was, what's going on? Why is it breaking? Is it a bonding issue? Is it the tooth structure? Why is it breaking out? And my comment to them was this: when you have a situation that you build a denture and then something's happening to the anterior teeth that they chip or repeatedly break out, it is in the wrong position. So it is in the wrong position in relation to the lower, whether it be a denture or whether it be a natural tooth. It is in the wrong position. And when the patient is chewing, it's contacting, but because there's less proprioception, which is a fancy word for there's no nerve into the denture and denture teeth, they can't feel it as diligently and as accurately as, say, someone with a full complement of teeth that can feel it. They can't tell, and they break it out. So my comment to them was, this tooth is telling you it's in the wrong position. If it breaks once, I could say, it was a one shot. It happens, things break. But when it breaks repeatedly and you're on your 3rd or 4th tooth now, and the patient's frustrated and you're frustrated because you're fixing all this for free, it's telling you it's in the wrong spot. Now you need to decipher and determine, what does that mean? So now bear with me as I jump back out. And let me just find the right frame here. Okay. So this is a patient. Nice. Okay, slideshow from current slide. Okay, we're just going to go with the hard way. Okay. Let me show you just a couple quick videos to show my point that the teeth are in the wrong position. This is a video taken from a doctor's office after we chatted about chew cycles. This is a complete upper denture, lower 6 anterior teeth. You can see there's a posterior partial. I want you to watch this patient chew, and then if you can really see it, you'll see the upper denture flex here because the upper's been breaking all the time. So watch. I have to get rid of my pen. There we go. Okay. Watch him eat. And you can actually see the plate flex in the middle between the centrals. This was after it was repaired. Okay, so when you watch him chew, you can see that he's chewing in a teardrop. And we're asking him to touch all the teeth together at the same time and slide into position. Like, that doesn't work. There's food between your teeth. They can't feel it because there's no nerve. And what's happening is because we gave this patient milling teeth, so 0, 10, 20, 30, 33 degree style of denture teeth, they're torquing the plate, and that's why they're splitting it. And so when you look at it again and you watch the centrals, you can actually see it break. Look at that. And this was inserted right after the repair, I believe. So it's just, so this is my patient. This is a lower implant retained denture to 4 locator implants. No, 2 locator implants, pardon me. But you see the wear? Look at the wear of the teeth. It's really noticeable. Look at that. Look at the wear down. And so I'm going to run the video and she's going to speak. And I want you to watch her mouth and her positioning of her jaw. So you saw how her jaw postures this way out to her left. So what happens when I rehabilitate this case and I put brand new denture teeth on that haven't been worn down, she's going to want to posture out here. If I keep the same overbite and overjet and anterior placement for all of the teeth, she's going to be breaking teeth on this side because her jaw swings out this way. So when I say the teeth are in the wrong position, I have to keep in mind that this is how her jaw works. It likes to come out to her left. So when I set the denture teeth, I kept that in mind. And now we're gonna go to the new denture. So now she has new teeth, and I kept spacing on this side, and she has never broken teeth off. So what I did is, if I get rid of my laser pointer and I run the video again, watch right in that lateral area. See the spacing? So when she talks, her lower left lateral actually moves ahead of the upper left lateral. It's brilliant. So when you can identify that, then you can set the teeth to accommodate that. It's not going to break. So now when I say respectfully, it's in the wrong position. Now you can take that back to the doctor and say, okay, we need to move the tooth into a different position, which could require a complete 6 anterior reset or 12 anterior reset. Yeah, but we got to stop this from getting any worse or breaking, or maybe I can just reset that one tooth a little bit forward without it looking odd in the setup. But or you can say, can you send me a video of their teeth, of them talking? Because what I've learned is your chew cycle is also somewhat related to how you speak. And so that's why I get them to say days of the week, months of the year, English and their mother language, if they have one, so that I can watch the posturing of their jaw. And so when anterior teeth break or chip, they're in the wrong spot. And then you need to try and get that information as to what's the uniqueness of the posturing of that person. And then you can make that correction in the lab. So that's just open dialogue and communication. And when the doctor phones and is frustrated that this is broken, and you can say, actually, I think I have a solution. I think the teeth are actually in the wrong spot, because that's why they're breaking all the time. We need to move them, but I need to know now the specifics of the person so that we can work together and again set it so that it works for that person. And then, hey doctor, in the future, send me a video on all those cases. And then what it does is this is just an effort to cut down on your chair time and your operating costs, so we can catch this in the future. You just want to say the right messaging. So I wanted to bring that up because that was also a really good question about why that tooth is breaking out all the time. And again, it's not the tooth manufacturer's fault. I'm waiting for Jim to chime in here. So it's not the tooth manufacturer's fault. I set them in the wrong spot, but now I've learned how to assess the patient. So I've eliminated, and I can control better so that I reduce that risk of those teeth fracturing. And it's greatly helped now that I have very little anterior tooth fracturing, because now I'm trying to watch the movements of the jaw better. Awesome. Jim, do we have another question?
Yeah, and kind of work with what you just said, right? We do get calls that, you know, people switch over to our teeth because the teeth that they used to use fracture. They say it fractures, but then we have customers that, you know, call us up and they say one of our teeth fractures. So for, you know, teeth fracture, denture teeth fracture, and as Mark indicated, you have to find the symptoms and eliminate the symptoms. The teeth, most commercially available teeth, premium teeth, are designed for heavy loads and for you know, constructed so that they distribute the loads throughout the entire tooth form. And when you get a fracture or you get a pop off, there's interference. There's some sort of it's not discluding the way it should when the patient chews, whatever their you know, chew cycle might be. Maybe it's that, maybe it's a tooth out of the place or something of that nature. But yeah, it happens, and when it does happen, it's a sign that something needs to be fixed. So make sure everyone understands that. So there is a question about chew cycles. Is there an article that someone could get that describes or mentions the difference of chew cycles so that it can be explained to their customer, to their dentist?
That's a good question. Other than watching my videos, I don't know of any, but that's a really good question.
We can do some research and have everyone get back to us.
You see my eyes going down. I'm trying to Google it now, a chewing cycle. So yeah, there is actually. So yeah, you know what? Yes, there is. When I just Googled chewing cycle, so there is different chew cycles, masticatory performance. You can see already just on Google, they're mapping that teardrop. I know it's not quite focused. They're mapping that teardrop approach that I talk about. So there are some articles there, or you pop onto YouTube and you can specifically edit out the clip maybe of me talking about it in some of my videos. But yeah, there's things here for you to Google, and or through the VITA North America YouTube channel, because I talk about it, and I put on videos of my patients and such, to show that there is a chew cycle, and then how did I identify that? Because of course I'm not watching the patient eat. Is I've learned to go through and watch their jaw posture when they speak, because when you speak, you have to phonetically move your jaw to pronounce the building blocks of the language. So in English, the building blocks are A, E, I, O, U, for example. So A, E, I, O, U, your jaw moves, and then when it moves, it's following that posture line. So that's why when I have them speak, I'm watching that, because a lot of times teeth chip when you're speaking, because again, they can't feel their teeth touch, and especially when you implant it down, they don't feel it, and that's when things are chipping and breaking. So I'm using that to help me identify it, because I'm typically not having the patient bring their lunch to my office, although I have gone to that extreme. But it does help. So yes, there's some articles. Yes, there's some stuff on YouTube. My silence is, just give me a minute. One of my videos is from the University of Strasbourg. Dun, dun, dun. Yeah, I would have to do some homework on this. One of my chew cycle videos was taken from the University of Strasbourg. I just can't remember the link because I've had it for quite a while. And it shows the mastication process of people eating an apple, some chewing gum, and some carrot. So it's an awesome video because it also shows you the rhythmicness of, and that there are different chew cycles that range from more vertical based to horizontal based. Other than some of the proprietary, some of the videos that I have of patients. But I hope that answers your question. You can do some work on Mr. Google because Mr. Google knows everything. And you can probably find some things to help with you in terms of clarification with the doctor and what you're looking for. The other thing that I wanted to quickly mention is on average, when we, and I'll just flip the camera around, in regards to that chew cycle now and articulators, here's just our standard crescent articulator. And typically we would move the articulator. So you would take your, get a better angle here. So you would take the articulator and we would do this. So you're doing this to do working and balancing occlusion, whether it is on a partial denture, for example, here, or even just a regular upper and lower denture here, articulated, and we would do this to the articulator to facilitate that. I don't do this anymore because even that you saw from just the quick video that I showed you of my one patient, they don't function like this. I actually pick the articulator and I emulate a chew cycle. So I can do that here on just a simple crescent articulator, and I can you know, take it and move it in and how she was doing it. So I've learned to take this articulator and move it differently and in what's my best interests and the patient's best interests. So you can do that with these crescent articulators, or I have a Cavo one, a Protar. So you can see it's in production. It's nice and dirty. And again, I don't do this. I actually move it in a chew cycle, and I'm moving things in a chew cycle. So I'm actually taking it, and again, I'm trying to emulate a chew cycle, and I'm doing this. Remember to go both ways, and I'm thinking, what's that chew cycle for that person? What am I looking for? And that's how I'm gauging how these lingual cusps are going into those fossas. I don't want them hitting the guiding planes based on the uniqueness of that chew cycle. And then all I'm doing is taking a very fine burr or rubber wheel and adjusting the guiding planes or such of the teeth. The nice thing about VITA teeth is that they are made from acrylic glass. You do not need to repolish them because they self-polish because of the glass particles. And they're the only tooth that can do that. You have to polish acrylic teeth. So all the other manufacturers, you have to polish them afterwards, or you leave it abraded, which is bad. These you do not have to do it, so it's a time saver for me. Awesome, Jim.
All right. So what is the best way to diagnose a speech issue problem and then correct it?
Okay, so the best way is days of the week, months of the year in English and their mother language, and then you can diagnose to see how they're phonetically moving their jaw. So from an overclosure perspective, or is that just how they're structurally built and how their golden proportioned are? And then whether or not it's correctable. That lady postures, that's her. She's been like that, I believe, forever. Although we don't have any videos of her in the past, I have what's there on her existing denture, what's there now in the finished product. And to this day, she still, when I see her postures over to that side, that's just how she talks. But on other people where they're overclosed, for example, in terms of the muscular structure, etc., you want to do days of the week, months of the year, English and their mother language to capture those building blocks and the jaw positionings. And then you would decide as the practitioner on a treatment plan what you think should be corrected. But this goes back to why are they in your office to begin with, and what are the symptoms? Where are they symptomatic? So if they say, well, just I can't chew, the dentures are dull and worn out, they're just, it's like a flat, a bald tire, I just can't grip anymore, then you can make that correction. But then from a speech perspective, are they complaining? And so to answer your question, it also depends on where they're symptomatic. That's a big one for me, is why are you here? And I ask patients that, why are you here? And let them answer. I need new dentures. Why? Because I can't eat. Why? So I sound like a 4-year-old, but I say to them, I need it in your own words. I'm not going to fill in the blanks for you, because I need to know that. What are you having trouble with? What's hampering you? So what I've done, and I want to share this with everyone, I've made a correction on how I present at a treatment plan and during a consultation. I say to a patient, the overriding mission statement that will help us decide what to do is quality of chewing life. That is the #1 statement, quality of chewing life. Under that is quality of life. You have to eat to live. So quality of chewing life is on top. Then that filters down to quality of life and everything underneath it. This is about quality of chewing life. What is impairing your quality of chewing life? And then they look and they go, well, yeah, okay. So what they want to see is all the decisions we make come back to, I want you to have a proper quality of chewing life. So that's the key phrases I use. That helps gain the information. So you can actually have the doctor say that, or if you're a denturist that's joining us, ask that now of your patient, or start using those phrases. And then you can always say, thanks to Mark Wagenseal, woo woo. But it's always quality of chewing life. What are we doing from there? And then why am I doing it? It always relates back to quality of chewing life, quality of life. That's how I see myself trying to be a superhero. I am trying to give you quality of chewing life, quality of life. That's why we're here. All of us, whether it's the doctor, the denturist, the dental technician, we are all part of this team to get quality of chewing life, quality of life. So that's what I do. I try to assess that, and then days of the week, months of the year, English, mother language if they have one, and then decide what the symptoms are, and then how can I improve that? So sometimes you have to do splint therapy or slowly open the vertical, and the treatment plan can last a year and a half. The patient has to be on board with that. It's, again, what are we prepared to do to go to quality of chewing life? How bad do you want to go? I also use this as an example. I say to patients, look, you can see I wear glasses. I need glasses to see. Sometimes they're loose, or if you sweat, they drop down, or if I shake my head, they're coming off. If that impairs my life, then I need to wear contacts. That's the next thing that we've invented to help, so that then the contacts go in your eye. Well, sometimes then grit can get under it. If I'm in a dusty environment, it's not good. contacts can only correct sometimes your vision so much, because if you have astigmatism and stuff. So if wearing contacts doesn't work for you, then they're going to look at you and say, well, then get laser surgery. And so you have to decide at what level do you want to go to again, quality of vision life, quality of chewing life, how far do I want to push it? But that's how I explain it to them, because then they have an example that they can relate to and go, oh yeah, okay. Especially the people, of course, that wear glasses, or if I say if you wear sunglasses, you know, they work, but there's a limit to them. And so we have to decide how far you want to push it. And that's why we have implants and dentistry, or these things that we can try and do to help you, depending on, again, your quality that you're trying to go after. So I hope that answers your question. That's, again, a little bit of experience about what I do and what's been effective from a treatment planning perspective, and for the patient to also accept different treatment plans. And then they see that actually you care. So if you can also, as a dental technician, bring that up to your doctor and have that discussion about terminology and phrasing to the patient as well. It's been very,
and part
very
of that, Mark, is
yes.
a follow-up is kind of like using the S sound, for new dentures versus old dentures, the S or sh sound, and whether or not the S sounds come from space between the upper and lower anteriors, or from the palate. So kind of some follow-up with using the S and sh.
Thank you, Jim. And to Jim's point, when we change something, you must remember that there's no nerve into the denture or the denture teeth for the patient to feel. But the central nervous system will understand that there is a change because their tongue is feeling it. Their tongue now has to go to a different position. Their lips are in a different position from the changes we made from the new denture. And it can take time for the central nervous system to learn those changes. How does it learn it? Practice. So again, crawl, walk, run. You have to practice, master the first one to get to the next one. So when I know, for example, I'm changing anterior tooth position or such, I'm very explicit in treatment planning about the central nervous system, and now what I've called denture integration into the body, and how your central nervous system understands the denture, functions with the denture. When you say that to a patient, remember, we're asking you to function with something you can't feel directly. The brain only feels around it. It uses the tongue, it uses the lips, and then it uses the hydraulics of the denture pushing on the gum. And this is the big one, especially on immediate dentures, and why we have issues with patient integrating to an immediate denture. They could feel their teeth before. I don't care what shape they were in the day they come out, they could feel them. And then you terminate that nerve, and then the gum has to heal over top. So the outside wound takes anywhere from 2 to 3 weeks to heal. And then the healing goes internal, where the socket had filled with blood. That blood turns to fiber, fiber turns to bone, and it solidifies into one piece. But we also have to remember the padding on top of that socket and that bone area needs to fill and correct itself, but the nerve endings need to heal. And the nerve endings and the myelin sheaths that surround the nerve endings need to heal internally, so that then you can push on it and hydraulically load it and hydraulically load those nerve endings without it hurting. So I say to a patient, you have to understand, it's like when you cut yourself. It hurts, you put on pressure. So that's what the immediate denture is going to do. And then that, eventually a week later kind of scabs over, and slowly the skin heals. So that's what's going to happen in your mouth. At about week 3, the outside skin is healing or healed, but then the internal, so even after a cut, you push on it, and when you push on it, it hurts inside, because the inside padding and gum and tissues has not healed yet, and the nerve endings have not healed yet. And that's why immediate dentures take so long to adapt to, because the brain has to understand the pressure change, but it can only understand the pressure change when everything is healed. So when the dentures are in your mouth, it's like a shoe on your foot. It is creating pressure. And when you're sitting, you're not on your foot, but the shoe is still contacting your foot, there's a certain amount of pressure. When the dentures are in your mouth, it's putting pressure down and holding it. And then when I swallow, like I just did, my teeth touch together, it put a little bit of pressure down. So that's when your brain learns, oh, that's swallowing. That's how much pressure is induced on the gum. And then when I chew, or for example, when I stand up and walk, there's more pressure put down. So then your brain starts to understand, now I'm eating, because it's learning, oh, okay, that's the hydraulic load. Switching subjects quickly, when a patient comes in and says, oh, my bite and I feel my left side healing more than my right side, they don't feel their teeth touch, because remember, there's no nerve into the teeth. They're feeling the pressure change. So to them, they're interpreting that because there's stronger pressure on the left side than the right, that the bite is wrong. And that's their interpretation, or the central nervous's interpretation of denture integration into the body. So that's also been another aha moment for me on my journey, is to educate patients, and I hope that can resonate with you a little bit, to help educate and explain to patients so they understand what's happening. And when you change the fit and change position, it takes time for the central nervous system to adapt. And the only way it's going to adapt is you have to time practice in patients. If I don't practice and I throw the teeth in my pocket, I'll never get used to them. I got used to without them. So if you can get used to without them, you can get used to with them. You just have to want to do it. Okay. So long-winded response again. How are we doing, Jim? Gosh,
we are doing fantastic. So I got one more. Are the Physiodens posterior set up like the lingual-form teeth for lingualized occlusion?
Yes and no. Yes, in terms of the red dot into the black dot. So there, Physiodens is, again, Physiodens. So there's, in 3, 2, 1. Thank you for that awesome question, my dear colleague. I had to hit the reset button. Physiodens is similar. So it is a freedom and centric tooth. So again, you have that little bit of wiggle within centric. The main lingual cusp is going to sit into the fossa of the antagonist of the lower. So it's like a mortar and pestle. So again, you'll have that red dot going into the black dot of the bottom bowl. The only thing different with Physiodens is that you are not looking for traditional working and balancing. With lingual form teeth, you still have the ability to have that cusp go up the side walls of the tooth and have contact per se, like lingualized occlusion, like we were used to with a milling tooth. But on Physiodens, you will never achieve it. It's not designed for that. So Dr. Eugen End, the inventor of that, his rationale was, again, what I've been talking somewhat about the chew cycle, and you don't want the tooth hitting the guide planes and sliding into position. So those teeth were designed on centric based with freedom and centric, but you're not supposed to hit the guiding planes. So there should be no contact on the guiding planes on Physiodens. So you are not looking for working and balancing contacts. You want to eliminate them. I hope that answers your question. That is in the hands of a tactile professional that understands that rationale and understands the chew cycle then, because the chew cycle influences those movements. And that's how that tooth was designed, with straight centric contact with an open bowl. So like a mortar and pestle, you don't want contact on the guiding planes of the teeth. Awesome tooth. Cool. Hope that answers your question. I remember, just as an aside, meeting Dr. End and having some private time with him all those years ago. It was brilliant. Also, again, you need people to push you. So my dad had it right when he said, Mark, you always want to hang out with people that influence you to be better. Or even if you just meet them once in your life, that you remember. It's about pushing it, right? So how I mentioned about the knee surgery and the day surgery, we're pushing it forward. So I'm appreciative of everyone's time and grateful for the time you've spent with us today in efforts to just, again, push us and our professions forward, because again, we're here for a patient that's trusting us to help them. Quality of chewing life. That's why they're in our offices. And then we as part of the team are there to try and get us to that goal. Jim, any other questions, or how are we doing?
No, that looks like it for today from my end.
Cool.
So,
okay. Those were kind of the big questions that I had sent to me. Yeah, see, there was a question about the PhysioDens, so thanks for bringing that up to our colleague that did that. I mean, basically, again, from a digital perspective, it's the same thing digitally. You just might, as our technology is getting better with digital and we can adjust the guiding planes and then have that milled out for us prior, that's going to help. Otherwise, you still have to do it by hand after the fact. So digital dentures will have the same issues in terms of the teeth having to function within a chew cycle. So the more you can control the teeth functioning within that chew cycle, the less adjustments you'll have after. So we are getting better with the software of helping that and just being aware of that digitally as well, because it matters. It's the same. Yeah. Okay, Jim, if you want to take over, if there's any other thing else last minute, anyone, type it in quick.
Mark, best way to get repeatable centric?
Best way to get repeatable centric. Wow, is that a complicated question? The easiest way.
It is the bear pit, you know.
I know. That's a complicated question because it depends what you're changing. The best way for a patient to find their physiologic centric is to don't get them to think. Don't ask them to do something consciously. You want them to do it unconsciously for you. That's how you'll reproduce it. So what have I learned? When I ask someone to bite or close, I don't use those words anymore. I use the word swallow. Please swallow. Swallowing is a subconscious act, a subconscious command. Then their brain is going to automatically do it. When I say the word bite, what does that mean? Bite is strong, hard. Bite means to actually physically get through something, bite through it, pierce through it, go through it. When you look up the definition of the word bite, so the patient's trying to do it really hard, and that's when you get these wrong occlusions and wrong bites and resets. I have learned now to say to a patient, I give them a sip of water, and I say, swallow. I get my hands off of them, and they give me the data raw, their own. So to answer your question in an easy, fundamental way is you want them to find their physiologic, reproducible centric themselves. And the only way that I know that at the moment is to use the word swallow, don't open. So they swallow. And if they need to, I give them some water. And then what that does is that helps me get to that reproducible centric. So I am trying to look up bite definition. So use the teeth to cut into or through something. So that's by definition the word bite. And when you use that word in dentistry, you're that's why I've stopped that word too. It was another aha moment. So to answer your question, use the word swallow. Great question. Difficult answer. Great question.
All right, one follow-up from one of the attendees about the chew cycle. They recommend a book called How Teeth Work by Lundin and Gibbs.
Mm-hmm. Yep. These are the guys that first followed the chew cycle and defined the pattern of Gibbs and Lundin that did the teardrop. Felix Pages had the privilege of meeting these guys and working with these guys. It was awesome talking to Felix about that. And so these guys followed that chew cycle, and it's defined in dentistry. That's correct. We have a teardrop cycle, and then it can change from person to person depending on their situations and how they're built. But these guys were the pioneers to define that. That is correct. Thank you. An awesome book. That is considered undisputable for us, correct? Like, and many other authors have substantiated what Gibbs and Lundin did as being correct. The idea behind this is just understand that when you set the teeth in the articulator, that has to mimic how it's going to work in the mouth. And the only thing I want you to remember is that there's a chew cycle. It's like a teardrop, and those teeth have to function within that teardrop of that person. If you can gain the information to understand what the teardrop is, yay for you, and then you can make the change. If you can't find the information out, hedge your bets. So then, again, as I speak respectfully but candidly, when I use milling teeth that are locked together and have no play in them, then how is it supposed to work here when there's play in this? This is why I use VITA Lingoform, because the teeth have play in it, and as there's play in here, I'm already helping myself. That's why I do it. And then that's why I use this product, because honest to goodness, Lingoform, this has been a game changer for me for all these years. It's dropped my adjustment rate. It's made things reproducible. And all I'm doing is just changing the guiding planes inside, and it's been working. And I'm able to what? Quality of chewing life. Get the goal. Be the superhero. That's
Excellent.
what I wanted to share with you. Thanks, everyone.
Great. So just everyone, your workshop, today's webinar has been recorded. A reminder, it'll be on our VITA North America website. You can reach us here at the help desk if you have any questions. And then if you need to reach out to one of the VITA North America reps, this is information on that. Remind everyone that, we do plenty of workshops and webinars with Mark and others. And this is kind of our list of some of the prominent ones for the rest of the year. And then we also have Mark scheduled to do a Class 2 remote denture workshop, October 5th and 6th. So if you're interested in that, please register. We will send you some models and the teeth, and then you'll have a chance to do it. I think we have it scheduled 2 to 3 hours each day for 2 days in a row. And you can sit there at your own lavatory and wax up and set up teeth following Mark's guidance. So that is available as well. We also have some next year denture programs at VITA Germany. If you're interested, please go ahead and contact us as well, and we can get you over to VITA Germany for a small fee. Those of you who are interested in more curriculum, more learning, more talking to others as well, we have a conference called the SCAD ProSec Conference, November 10th and 11th in Chicago. So if you're interested, please visit the website, visit VITA North America. We also have it on there to help you register. It's nominal fee. Contact your rep, contact us, and we'll get you registered on that as well. It's going to be really a nice program for this year. This is Mark's information as far as please make sure that you understand that Mark is a working denturist technician, so he's plenty busy, goes on many trips as far as lecturing and courses. So if he doesn't get back to you right away, don't worry about it. He'll get back to you. But just expect that it's possible it'll take a day or two for him to respond. So
we are here to support you. So
yeah,
Jim and team and myself.
Other than that, Mark, any last minute things you'd like to go over, or any last minute comment?
Other than thank you for your time. Thank you again to VITA North America, Jim and the team, for their kind support of our professions. And thanks to everyone for taking time out of your days in efforts to learn, grow, and share as part of our community to again look after our patients. So thanks for hearing me out. If you have any follow-up, again, please fill out the questionnaire form when you get the email in a day or two. If you like this style of program, we certainly can do a bear pit again based on your responses. So we do appreciate you taking a quick moment to say, yes, do it again. Even that's enough. So thank you. And again, thank you for yourselves and again, efforts to try and, again, quality of chewing life and be that superhero. So thank you. I'm very blessed to have this opportunity to share my journey with you.
Thank you, Mark, and thank you everyone for registering and attending today. It's been fantastic. Mark's a great, library of wealth of knowledge. So it's always nice to hear Mark explain these things, and he does it in a way that really breaks down the essentials of it, so that it's not over everyone's head, which is excellent. And again, Mark's information is on the screen. If you need to touch base with him, please do so. But thank you very much for attending today. I hope to see you again on another webinar.
Yes.
Mark, it's been great, as always. So thank you very much for spending your time helping us out on the education front.
Pleasure.
And I want to wish everyone a good day wherever you're at. And then this will conclude today's webinar.